campaigning happening against immunization, and we have the responsibility to uphold this particular public health program. So, having a thorough knowledge about immunization is very important to do that responsibility, and that is why this program has been planned by Dr. Johnny and Nisha, and they have made available the most eligible teacher for doing this particular program. So, all the best for the program and happy learning. Thank you.
Thank you, sir. Now, our President-elect IAP Kerala, Dr. Nandakumar sir, is also here. So, I invite sir to say.
Respected dignitaries on this platform, thank you for this opportunity. First of all, let me congratulate Team IAP Kerala, led by our dynamic President Riaz and team, and Dr. Johnny and team for arranging such a wonderful program for the budding doctors. I think, as Dr. Riaz already mentioned, immunization is one of the most important things every doctor should know. Not only for it may be useful for their own children and the public. So I wish all the very best for this program. Thank you very much.
Thank you, sir. Now, our IAP Kerala Secretary, Dr. Gobi Mohan sir, is also here.
Yeah, Nisha, to start with, congratulations on getting a DM unit nephro in GMC Trivandrum. Respected Riyaz, incoming President Nandumar sir, Johnny and Nisha, esteemed speakers, Sheeja madam, and all the delegates here. I wish this program a very success. I think we should not lose time and directly go to the academics.
Thank you, sir. Now we will be directly proceeding to the talk. We have Dr. Sheeja madam for another session on practical issues in immunization. We know that in January we started with Sheeja madam's talk, and it was as houseful as expected. So now we will be going to immunization talk by madam. Madam is an expert in immunization also. So over to Sheeja madam. Madam is a professor pediatrician in SAT Hospital and is in charge of the PICU also. So over to madam.
Thank you, Nisha.
One minute. Nisha, please share the YouTube link in the group also, because so that they can share it with the friends. The Zoom is already full.
Okay, sir.
Okay.
So good evening, everyone. So first of all, I thank the team IAP Kerala led by Dr. Riaz, Dr. Gobi Mohan, and also, of course, the chairperson and the convener, Dr. Johnny Sebastian and Dr. Nisha for giving me this wonderful opportunity. I also thank Dr. Nandakumar and Dr. Joseph Patani for joining us today. So going straight to the topic, that is immunization. Let me just share this slide. I think it's visible, right? Visible, alle?
Yes,
visible. Right. So we move to the topic, that is practical issues in immunization. So what are we going to learn today? We are going to start with some basic immunology and principles of immunization, because unless you know a little bit about the principles of immunization, we will not understand the reason why certain solutions are there. Because whenever somebody says that it should be done in such a way, why should it be done? For us to understand that, we need to know a bit of basic immunology. Then we will naturally move on to preterm and low birth weight immunization, because one of the neglected areas is that. Then next would be mumps and monsoon diseases. That means the outbreaks that we are currently facing or the outbreaks that we recently faced, how to act during those situations. We'll touch also upon immunization errors, and of course, always the hot topic, that is rabies prophylaxis failures, causes and solutions. So first of all, how does a vaccine act? We all know that when a vaccine is administered, we have antigen-presenting cells, the macrophages, dendritic cells, B lymphocytes, which normally don't do anything. They're simply moving around. But the moment a vaccine is administered, the antigen-presenting cells come, catch hold of the vaccine, and take it to the regional lymph nodes. On the way to the regional lymph node, it processes it and expresses it on the surface. If it is recognized by the B lymphocytes, it will stimulate the B lymphocyte to make IgM antibodies and a small amount of IgG antibodies also. If the vaccine is also recognized by the T lymphocytes, it will help the B lymphocyte migrate to the germinal center, cause a germinal center reaction, convert itself into a plasma cell, and start producing a large amount of IgG antibodies. These IgG antibodies also die off after some time, but some of the B cells escape from and hide in the bone marrow niches and continuously produce small amount of IgG antibodies, while some of the B cells get converted into memory cells. So this is the most important slide. So what did we understand from this slide? We understood from the slide that the moment the vaccine is given, you don't get an antibody. You are not protected. It takes some time for your body to react to an antigen or vaccine. So when first time you're receiving a vaccine, it classically takes around 1 to 2 weeks to have an antibody. We also understood that if the vaccine is going to stimulate only the B lymphocytes, we are not going to get memory cells. We are only going to predominantly get IgM antibodies. So what does that have practical implication? If you have to choose between a polysaccharide vaccine and a conjugate vaccine, always opt for the conjugate vaccine, because polysaccharide vaccine does not stimulate T lymphocytes and there are no memory cells. The classical example is typhoid. You have typhoid conjugate vaccine and you also have typhoid polysaccharide vaccine, the Typhorix, which is available. So if you take a polysaccharide vaccine, you will need to take every 3 years. If you take the conjugate vaccine, you need to take only once, and it can be even given to a baby as young as 6 months. So whenever an option arises, always opt for the conjugate vaccine. We also understood that once a vaccine is given and the body produces antibodies, even those antibody levels over time comes down because the antigen producing cells die off. But those cells which hide in the bone marrow often helps us to have a sustained low level of antibody. But most important is the memory cells, which is going to help us in case of re-exposure. So with that, we will now move on to the scenario. So we all know what are the vaccines that we give at birth: BCG, hepatitis B, and OP. And hepatitis B ideally should be given within 24 hours because you're aiming to prevent transmission of hepatitis B from the mother to the newborn. So that is why it is known as the birth dose, and as far as possible, it should be given within 24 hours. If for any reason it is not given within 24 hours, the national schedule does not allow you to give beyond 24 hours. But if you are working in a private sector, always try to give it within 24 hours. That's a priority. If that doesn't happen, then don't deny it. You definitely give after that also, because horizontal transmission can also occur. So now the question is, which is the most common scenario with the newborn that you are going to face? When you have a normal term newborn, they come, they take the vaccine. You don't even have to prescribe. The sister knows, the patient comes, they give. But what about the tiny ones? The ones who have SGA with a low birth weight or a preterm? For how young you can give? How low a baby or low birth weight baby can you give a vaccine? So many people may tell you many options. Many times it happens that the baby comes to the immunization clinic, and then you send them back telling that the baby is too tiny to receive a vaccine. So what is too tiny? What do you mean by that? So before you answer that question, that can I give the vaccine? The first thing that you need to remember is that preterm babies are highly vulnerable. The risk of them getting an infection is much more than a term baby. Example, pneumococcal infections are 9 times more risk of having a preterm getting a pneumococcal infection than a term baby. So every infection, the risk is more. That means in the preterm, the need is more. So there should not be any doubt about it. So what is the recommendation? Hence, the recommendation is vaccinate according to the chronological age, not post-conceptional age. That means the baby is born at 30 weeks, the baby is born at 38 weeks, the baby is born at 40 weeks, whatever be it. After delivery, what is the chronological age of the child? Depending on that, give the vaccine. So what is the vaccine to be given at birth? Give the vaccine at birth, provided the baby is medically stable. So a very tiny baby, a 28-weeker, a 30-weeker is not medically stable at the time of delivery. So naturally they go to NICU, and once they are stabilized and they start growing, you usually vaccinate them. Here also, if the mother is HBsAg positive, none of this scenario comes. Irrespective of the weight of the baby, irrespective of medical stability, you will definitely give hepatitis B vaccine. So who is medically stable? Medically stable is any baby who's not currently receiving any life-saving support or getting a severe infection getting treated. So any baby who is coming to you in an OPD is definitely medically stable. It doesn't mean that children with, sometimes what happens, you don't give a vaccine telling that this baby is small, the baby is having a heart disease, so I'm not giving the vaccine. No, baby with heart disease is more prone to get an infection. And if that baby is coming to us in an OPD, that means this baby is stable and this baby can definitely get vaccine. So now what is the recommendation? Any babies more than 31 weeks or more than 1.5 kg, if medically stable, can receive BCG vaccine. That is even at birth. So at birth itself you can give if the baby is medically stable and more than 31 weeks. For others, once they are stable, you can give the vaccine. I hope that is clear. So don't deny vaccination telling baby is too small. And hepatitis B is the only vaccine where we say immunogenicity is better, but when the baby is 2 kg. But hepatitis B in both national schedule as well as IAP schedule, we already give 4 doses. So never hesitate in giving hepatitis B vaccine also at birth, at least before discharge, irrespective of the birth weight or the weight at which they are presenting to you. So every child who is going from the hospital should be vaccinated according to the chronological age, and every child who is coming to your OPD for a review should be vaccinated irrespective of the current weight. I hope that's clear. Now we move on to the second scenario. Now this is a baby who had received the first dose of Pentavac at 6 weeks of age. He was asked to come for the next dose of Pentavac 1 month later. But what has he done? He has been brought earlier. So he was asked to come on February 12th. He has now come on February 9th. So can we vaccinate this child? So we should know that when you are giving 2 vaccines, they should be separated by minimum 4 weeks. 2 vaccines means 2 same killed vaccines. So you have given a Pentavac, you're going to give the next dose of Pentavac. It has to be separated by 4 weeks. 4 weeks minus 4 days is valid, but anything more lesser than that is invalid. So once you say it is invalid, what should you do? You have to repeat the vaccine 4 weeks after the invalid dose. So the message is always try to maintain 4 weeks gap between 2 doses of the same vaccine. Now, what if this child is coming after, say, 1 year of age? Don't worry. Just continue your vaccination from where stopped. No need to restart. That means 6 weeks he has taken the first dose of the vaccine. He's coming to you in 6 years. Give the second dose of vaccine that day. You can give the third dose 1 month later and booster 6 months later. So you just continue from where stopped. Now, why do we insist that minimum gap should be 4 weeks? We insist minimum gap should be 4 weeks because when we give a vaccine, the body produces memory cells as well as plasma cells. Plasma cells are the effector cells which produce the antibodies. Now, when you give the second dose of the vaccine, the body produces higher number of plasma cells and higher number of memory cells. So the increase in titer will happen only if you give at 4 weeks interval. If you're going to give the second dose of the vaccine, even before the memory cells following the first vaccine is produced, the titer will not be higher. So this exponential rise in titer to occur, you have to maintain an interval of at least 4 weeks. Hope that's clear. So now another scenario. This is also extremely common. Many times IPV becomes, has a shortage in the private sector. So the patient will go to the private sector, take all other vaccine and come to you in the government sector 2 days or 3 days later and ask for IPV. So can you give an IPV? So here, how is it different from the previous scenario? Previous scenario, the patient had come for the same vaccine. Here, the patient is coming for a different vaccine. So here we should know that different killed vaccines can be given any time before or after any vaccine. He has received Pentavac yesterday. Today you can give IPV. He has received Pentavac last week. Today, if he needs, he can be provided IPV. Why do we say so? Because when you're giving a killed vaccine, you are injecting it to a particular site. It is not going to multiply. It is going to be drained to that particular regional lymph nodes from where an antibody is going to be produced. Next day, you are going to give another vaccine. It is going to go to another group of lymph nodes, and it is going to produce vaccine specific antibody specific for that particular antigen. So there is no interference here because there are two different types of antibody. So any killed vaccine can be given any time before or after any vaccine. That is the second principle. Now we move on to the third scenario. Here, what is the problem? 15-month-old Alankrita had received MR 2 weeks back, but now her uncle has varicella. What can we do? So this scenario you yourself can face, right? You are in the hostel and your friend develops a chickenpox. Now what do you do? So here you need to know that chickenpox vaccine has excellent post-exposure prophylaxis. That means even after you come in close contact with the varicella case, if you take the varicella vaccine, within 3 days of exposure, the protective efficacy is close to 90%, highly effective post-exposure prophylaxis. So here, the baby has an intrafamilial contact with varicella, and varicella, the secondary attack rate is pretty high, more than 90%. So ideally, if we give her a varicella vaccine, she will be protected from the disease. But here, what is the problem? This baby had received another live vaccine, that is MR, 2 weeks back. So now what is the guideline? 2 live injectable or intranasal vaccines should be separated by 4 weeks. You can give 2 live vaccines on the same day, no problem. But if you're not giving on the same day, it has to be separated by 4 weeks. Now, why do we say so? When you're giving a live vaccine, it does not remain confined to the site of administration. It will multiply and spread to the whole of your body, mimicking a natural infection. So the whole of your immune system is now hyperactive. And now when you give the second vaccine, your innate immunity will destroy can destroy the second vaccine. So which vaccine will become ineffective? The vaccine which is given second will become ineffective. So here you have to understand, if you give a vaccine, like 2 live vaccines, less than 4 weeks interval, it doesn't harm, but it may not benefit. The second vaccine will be ineffective and it needs to be repeated 4 weeks later. So that is regarding the 3 basic principles of vaccination. So now we move on to the next scenario. You have a 3-year-old child. This we had seen, I think 2012 or so. She had come, she was that those days diphtheria was not common. You should know that as a postgraduate, none of us had probably seen a diphtheria cases, but unfortunately, now it is not a rare disease at all. So always remember, just because you don't see some diseases around does not mean that they have disappeared from the face of the earth. They can always come back when your immunization status comes down. The moment the immunization status comes down, it doesn't reappear. But once someone gets, it spreads like a wildfire. So it's important to know. So this was one of the initial cases. So she had presented with a patch in the throat. The local physician had diagnosed or suspected diphtheria in those days even. She also had bleeding from mouth and was referred to us. She had thrombocytopenia. She went on to develop renal failure requiring a dialysis. Then she had cardiac myocarditis. And once she recovered from myocarditis, she went in for a complete GBS-like paralysis. Now, what is the problem here? This was a baby who was born in Tamil Nadu and had received the 6 weeks vaccine. That has received the 6 weeks DPT. And then they had shifted to Trivandrum. And after that, due to some misbelief in the locality, they had stopped vaccinating. But now when the baby is presenting to you with diphtheria, she had all the complications described in the textbook of diphtheria. You cannot have diphtheria more severe than this. So the question is it vaccination failure? So it is extremely important to know that when we are giving a vaccine, the killed vaccines, the initial doses are only sensitizing doses. They do not produce protective level of antibody. They just produce a small amount of antibody. It's only when you complete your primary series, do you have an antibody level above the protective level? So here what had happened, our child had taken only one dose of DPT. One dose of DPT is not going to protect you. It's only when you complete the primary series are you going to be protected. So in this case, we cannot call it as a vaccine failure. This is like as good as being unimmunized. So there lies the importance why a schedule needs to be completed to call yourself protected. Now we move on to the next case. 10-month-old child is brought to the OPD. Why is your baby angry? Your baby is totally upset because he has been vaccinated only till 6 weeks of age. No further vaccines. So he's surprised that he's left unprotected in this world, and he's also not happy with the doctor because doctor now wants to give multiple injections to him. So the question is, how do you plan a catch-up vaccination? So what you may have different scenarios, isn't it? You may have a totally unimmunized child, maybe someone who has taken one dose, maybe someone who has taken 2 doses and is coming now. He may come 1 month late, he may come 1 year late, he may come 10 years late. Then what should you know? There are some basic principles of catch-up. If we know those basic principles of catch-up, however differently the patient comes, we can always plan the catch-up vaccination. So what are the principles of vaccination? Number 1, if a schedule is interrupted, there is no need to restart. Continue from where stop, as I told you earlier. Because the first vaccine that you had given, it had produced some memory cells. It is still remaining in your body. It has not gone anywhere. The longer the interval between vaccines, higher is the antibody titer. So you don't have to repeat it. Only exception may be oral typhoid. Oral typhoid comes as a complete package. So 3 capsules have to be taken. Otherwise, in all other cases, there is no need to restart the schedule. Regarding number of vaccines, how many vaccines can you give on a single day? How many vaccines can a baby respond to? A baby is capable of responding to more than 10,000 antigens at a time. So don't worry about the number of vaccines. Any number of vaccines can be given on the same day. If you plan to give 2 vaccines on the same limb, then separate it by 2.5 centimeters. If the patient is coming at 10 months and the mother says that I don't want multiple pokes, I just want a single poke today, I'll come back for the rest of the pokes, then the priority is always, remember, measles vaccine, because measles is a killer disease. Measles is an immunosuppressive disease, but counsel them as far as possible and try to vaccinate them early simultaneously, because the idea is to only after the baby has completed a schedule is the baby really protected. Now, vaccine interval, we have already said about live vaccine, killed vaccines, and same vaccine. So same thing applies here. Next is vaccine boosters. When do you give vaccine? We need to complete the schedule as early as possible. So once you have given the 3 primary doses of DPT or Pentavac, the booster has to be taken 6 months later. So booster is only 6 months away, not 1 year later. And between 2 boosters, usually you maintain a gap of 4 years. Then the complication comes when you have an upper age limit. So we should also know the vaccine's upper age limit. Only then we can plan the vaccine. So regarding upper age limit, there is a small disparity between national schedule and IAP. The disparity arises because national schedule aims at vaccinating the child when it makes much of the economic sense. Whereas IAP, when they say the schedule, they are looking at each individual case separately. So you should know, in fact, no vaccines have an upper age limit except rotavirus and DPT vaccine. DPT vaccine is recommended only till 7 years of age because of the pertussis component or diphtheria component may be more reactogenic in the older age group. So DPT has an upper age limit of 7 years. Regarding rotavirus, in office practice, the upper age limit is different. Whereas in national schedule, rotavirus can be initiated up to 1 year of age. And if initiated at 1 year of age, before 1 year of age, it can complete it in the 2nd year also. So that is regarding upper age limit, but in office practice, we do not give the first dose after 15 weeks and the last dose after 8 months. But I think you better stick on to the national schedule guideline of 1 year for starting a rotavirus vaccination. So now what will we do for our baby? For our baby, since our baby is 10-month old, if he's completely unimmunized, he can receive the BCG. She can receive 3 doses of penta, OPV, and rotaviruses 1 month apart. And she also needs to receive PCV and IPV, 2 vaccines where the interval between doses is 8 weeks apart. Now, IPV 3rd dose, you can say may be given 8 weeks later, but ideal would be IPV 3rd dose being given 6 months later, because immunologically that is a better schedule. 0 to 6 would be any day better than 0 to 3. Then MR and MMR, again you should know MMR has no upper age limit. Any one of us can take MMR. So MMR can be, or MR can be offered at 10 months, and again he needs to be taken the 2nd dose subsequently. JE should also be given. Typhoid, even though it is not there in the national schedule, it can be offered to any baby who is more than 6 months of age. Only single dose of typhoid vaccine is needed. That is, this is typhoid conjugate vaccine. Typhoid polysaccharide vaccine can be given only after 2 years of age, and that is not preferred. Typhoid conjugate vaccine is always preferred. Polysaccharide is not preferred. So I hope you understood a rough idea of how to plan a catch-up immunization. Now, we move on to the next case. So 13-year-old Karthik has sustained an injury while playing football and is brought for TT, right? For tetanus TT, nobody comes and asks you, Doctor, TT edukano. That nobody asks. They come and say, Doctor, TT venam. They demand the tetanus toxoid. So now, but as a doctor, the question is, if you give TT to this child right now, will it really protect him against tetanus? If it is going to protect him, how long does a dose of TT protect? Now, what is the role of tetanus immunoglobulin? So this is one of the most, I think, misused vaccines. And you should know that too many TT taking is not good. It can cause serum sickness also. So that is also important, which may manifest as rashes or arthritis. So what is the real recommendation? Remember, standalone TT, that is a child who has never taken a TT or a TT containing vaccines, that is DPT or TD, anything in the past, and has now an injury and is coming to you for the first time to take a TT, this TT is not going to protect him against tetanus. What do we mean by here? Tetanus is a disease which can have an incubation period as short as 3 days. If you're receiving the vaccine for the first time, your body is going to produce an antibody only 2 weeks later. So at this point, this TT is not going to be effective. Taking a TT after injury will be effective only if you have previously taken a tetanus toxoid. So previously taken at least 2 doses of tetanus toxoid. So remember, if you take a single dose, there is no protection. If you take 2 doses 1 month apart, the protection lasts for close to 1 year. 3 doses, that is 0, 1, 6, will give you protection for close to 5 years. So whenever you get a patient for tetanus toxoid, please ask him, have you previously taken tetanus toxoid? If the answer is yes, I have previously taken tetanus toxoid, then you can give the next dose today if it's a tetanus prone injury. But if the answer is no, I have not previously taken a tetanus toxoid, then you have to give him 3 doses, 0, 1, 6, followed by a booster 1 year later. So again, I will re-emphasize, only if you have taken at least 3 doses of TT are you protected. And 3 doses of TT is going to protect you for the next 5 years for a tetanus prone injury. A 3rd dose TT you are taking, for the next 5 years, even if you have a tetanus prone injury, you really don't require a TT. But if it is after 5 years, you require a TT booster definitely. Now, if your patient has received less than 3 doses of TT previously, and he currently has a tetanus prone injury, he requires both tetanus immunoglobulin as well as tetanus booster. Because only if you have had 3 doses of TT previously, will you have enough memory cells to mount a rapid response against the disease. Otherwise, you cannot mount. So anyone who has not taken at least 3 doses of TT and is currently having a tetanus prone injury. If it's not a tetanus prone injury, you can just give a TT booster. But if it is a road traffic accident, you need to give TIG. At the same time, you should understand anyone who has taken at least 3 doses of TT in his lifetime, even if he has a tetanus prone injury, even if he has a road traffic accident 5-year, 10-year later, he doesn't require a tetanus immunoglobulin. He only requires a TT booster. Am I clear? If you have taken 3 doses of TT in your lifetime, you never require tetanus immunoglobulin. You only require TT booster if it is minimum 5 years since the last dose of TT. Now coming to some of the diseases which have now reappeared. One of the diphtheria we already said, and recently what we had a massive outbreak of mumps. More than 70,000 children and adolescents got infected with mumps. So the question came that in the national schedule, we were giving MR vaccine. So many parents came and asked for MMR. So can you give an extra dose of MMR that has already received 2 doses of MR? Can you give now an MMR? Will it harm? You're giving too many doses. No, 2 doses are recommended. Now you're giving the 3rd dose. Will the side effect be more? And total, how many doses of MR or MMR can you give? So here you should know that as far as live vaccines are considered, extra doses do not harm. Because if you are previously vaccinated and you have antibodies in your body, when you give a next dose of the vaccine, the preformed antibodies will come and kill the vaccine virus if you are immune. So even side effects will be less. So live vaccine, as the number of doses increase, the side effect decreases. Killed vaccine, as the number of doses increases, the local and systemic side effect increases. So side effect also, you don't have to bother. So then people say, maybe when I'm taking too many vaccines, won't the preservatives get accumulated in my body? You should know that the live vaccines like MR and MMR do not contain preservatives. So that also you don't have to be bothered. Then what about maximum doses? There is no definite guidelines, but 3 doses can definitely be taken. So whenever you have an outbreak of mumps, if you receive a patient who has previously received MR, you can definitely offer MMR to the child, provided it has been at least 1 month since the last dose of MR. And even for patients who have already received 2 doses of MMR in the childhood, and now in the hostel you are having an outbreak. So it's, for example, you yourself may have taken MMR in your childhood. Now you're 20, 25 and you are having a mumps outbreak in the hostel. So then always better to take an extra MMR booster, because mumps protection usually lasts for only 10 years. After 10 years, the antibody titers come down and the chance of chance of having a mumps increases. So the last vaccine was more than 10 years back. There is no harm in taking an extra dose, even in case of an outbreak. So now the next outbreak, which is going on, in fact, that is hepatitis A. Maybe 2-3 years back, there were hardly 50, 60 or 100 odd cases of hepatitis A. And last year, we had more than 6,000 cases of hepatitis A. I think Malayali has moved away from the practice of always using boiled water or hot water. That was a norm in the olden days. And now we are more prone to get tap water, drinking water, other waters, and your filter water, which may not be completely disease proof also. So we are seeing a lot of hepatitis A outbreak. Now you are in a hostel and some of your friends have got hepatitis A. What can you do? So you may have also ingested the same water and the virus may still be there in the body. So you should know that this is one of those vaccines which again has a post-exposure prophylaxis. So what do you mean by post-exposure? That means you have already got the virus in your body, but the vaccine can protect you before the disease gets manifested. So you have both live and killed vaccine. So these were the cases, both live and killed vaccine. Either of these vaccines may be taken. So here, hepatitis A, if it is the live vaccine, single dose is enough. If it is killed vaccine, it is 2 doses, 6 months apart. But remember, even killed dose, a single dose itself is highly effective. So please do take the vaccine, especially since we have this outbreak going on. And typhoid cases, especially drug-resistant typhoid cases, are also unfortunately increasing in Kerala. Again, another reason of food and water contamination. And here, any one of us can take a single dose of typhoid conjugate vaccine. Even though it is recommended till 45 years of age, even those above can be offered in an outbreak situation. It is a more better vaccine. Then, of course, the rain has come, H1N1, H3N2, everything is coming back. And definitely anyone above 8 years can be offered the seasonal influenza vaccine. So especially patients with chronic comorbidities like having a diabetes, having an interstitial lung disease, or someone on a chemotherapy or a malignancy, or someone with asthma, definitely recommend influenza vaccine. Less than 8 years, first time when they are receiving, you need to give 2 doses 1 month apart. And then every year you have to give. More than 8 years, we can take 1 dose every year. Remember, it is an yearly vaccine because every year the strain changes and you need to take the latest vaccine which is available in the market. So now coming to the vaccine route. So till now we were talking about doses, intervals and all. So now do we have problem with route? So we know where is hepatitis B given? Usually in the anterolateral part of the mid-thigh. But where did the baby receive? The baby received the hepatitis B in the gluteal region. And of course, the baby is not happy about receiving the vaccine in the gluteal region because no vaccine should be given in the gluteal region, especially hepatitis B, HPV, and rabies. If given in the gluteal region, it is considered invalid. Why is it so? It is so because the number of dendritic cells in the intramuscular plane, we have a lot of dendritic cells. Remember the first slide? Dendritic cells are the antigen presenting cells which are going to go and catch hold of your vaccine. So if your vaccine lands up in the subcutaneous plane, the number of dendritic cells is less. So your vaccine will become less immunogenic. When you're giving the vaccine in the gluteal region, the chance of it becoming subcutaneous is high. That is why vaccines are not recommended in the gluteal region. So now we come back to the disease which is always under the lens or always under focus, that is rabies. So we are always saddened whenever we hear rabies post-exposure failure. So we will just briefly go through why failures happen and how to prevent that. And for that, again, we need to know what happens in rabies. We know that when a rabid dog bites, the virus gets localized at the site of the bite, and it can remain at the site of bite for days to weeks to months. So this is something important you should know. The virus can persist at the site of bite for days to weeks to months because this is not a virus which causes viremia. It just remains there slowly multiplying till it finds a nerve. The moment it finds a nerve, it will enter the nerve through the neuromuscular junction and ascend upwards. Inside the nerve is like a safe haven for it. It will start multiplying. At the same time, once the virus is inside the nerve, your antibodies, your immunoglobulin, your vaccine is not effective. You need to catch hold of the virus before it enters the nerve. So when it is entering the nerve, that is the tingling sensation the patient would complain. So this tingling sensation may appear anytime later. Whenever the nerve is being found, the patient will complain of the tingling sensation. And once the nerve reaches the spinal cord, if it is a lower limb bite, the patient may complain of a girdle pain. If it is an upper limb bite, it may complain of a shoulder pain or a neck pain. And then the virus will reach the brain. Remember, throughout this journey of the virus from the site of bite to the brain, in fact, the patient is not symptomatic. Patient is not showing any features of rabies. It's only after it reaches the brain, the virus multiplies rapidly and it travels down through the nerves, reaches the saliva and tears, and that is the time the patient becomes infected. And as you saw, the virus travels at a rate of 2 to 4 centimeters per day. Different books may tell you slightly different rates also. But whatever it is, this is the reason why bites on the face and neck usually have short incubation period, and bites on the leg usually have a longer incubation period. So we need to know that the current classification of the category of wound is not based on the site of injury. it is based on the depth of injury. Because the moment there is a skin break, a nerve is exposed and the virus can enter the nerve. So it depends, remember again and again, it is not the size of the site of bite, neither the size of bite, but it is the depth of bite which decides whether a bite is category 1, 2, or 3. We should also know that the virus gets excreted in the saliva intermittently, but at the time of death, all patients will definitely have a salivary rabies antigen positive. So before that, if your suspicion is high, we need to repeat the samples also. So now what is the cause of post-exposure prophylaxis? So this was a study where they had collected data from different continents, and what did they find? Of 122 cases of post-exposure vaccine failure. That means you've given a post-exposure prophylaxis, till it has failed. What they found was that majority of failure happened when they had an injury in the head and neck. Now, why do head and neck and especially hand has a higher chance of failure? Because these are highly innervated areas, and highly innervated areas, whenever you get a bite, the chance of the virus finding a nerve is very high. So that is why the chance of failure is high when it is in the head and neck or hand bites. But they also found that 56% had deviation from the core practices. So even though theoretically we are telling that they have received post-exposure prophylaxis, but more than 50% had deviation from core practices. So what is core practices? Core practices are the 3 things, that is wound care, administration of rabies immunoglobulin, and of course, have the site of rabies immunoglobulin administration. Now, what is wound care? We all know this is of utmost importance. Always tell the patient whenever the bite happens, do not rush to the hospital. First, rush to the nearby tap and wash it thoroughly for 15 minutes under running water. So if he's coming to your hospital, having a hand shower is extremely good, so that the wash can, because leg can always or hand can always be shown under a tap. But if you have a body bite, it will be difficult to clean. So that is why it is recommended to have a hand shower so that any site in the body can be approached, and wash it with soap and water, because this again is virucidal, and the 70 to 80% of the virus will be washed off from the site of wound. Washing alone, wound care alone can prevent 30% of rabies. That is, you're having a rabid dog bite, still 30% of them will be protected if you do a good wound care. And so do not underestimate this particular step. After you have washed, please administer povidone iodine or surgical spirit, because they are virucidal agents. Now, once you have done that, the next job is naturally to give immunoglobulin. So immunoglobulin has to be given for category 3 bite and category 2 and 3 bites in immunocompromised, and also all wild animal encounters, immunoglobulin has to be administered, irrespective of the category. So you have an encounter with a fox, you have an encounter with any wild cat or any wild animal, this has to be given. And those we all know. But what is main importance of rabies immunoglobulin? You remember what it does. The rabies immunoglobulin is going to neutralize the virus which is present at the site of injury. So that is, it is preformed antibody. It will immediately neutralize the virus. So this is the most important step. And so just look at the upper one. Even the small scratches, each and every scratch needs to be infiltrated. So sometimes some people, what they say is that the moment you take an immunoglobulin, you calculate the dose and then you divide in different syringes. The first syringe is given locally and the other syringes are given intramuscularly. No, never do that. You have to administer rabies immunoglobulin locally at each and every wound, because even a minor scratch where blood has appeared, the nerve is already exposed. If you don't give the immunoglobulin, the virus may enter the nerve, and once the virus is inside the nerve, neither your vaccine nor your immunoglobulin is going to be effective. So usually what happens when there is a large wound, we may be concentrating on the large wound, but we may be missing on the small abrasions by the side. So that should not happen. So you can also do a spirit swab. That is, once you have infiltrated the larger wounds, with the spirit, you can wipe the other wounds and other areas, the nearby areas, and ask if there is a burning sensation. And if there is a burning sensation, infiltrate those areas also. But sometimes it is a small child and you cannot ask all these. The baby may be howling and crying. In that case, what you can do, if you want to give IM, give it closer to the site of injury. So always remember, intramuscular administration of rabies immunoglobulin has very limited value. And the second, if you notice the second administration, you can see that is a open wound. And here the administration is, you have to go to the base of the wound, just below the base of the wound, and infiltrate the rabies immunoglobulin. It should ooze out of the wound. So one of the complaints a recent patient had given was when the doctor administered, the medicine came out. In fact, that is the way the WHO describes it. Go to the base of the wound, just below the base, infiltrate the rabies immunoglobulin. It just oozes out through the surface of the wound. That means you have infiltrated it appropriately. So again, emphasizing, for category 2 bite, normally it is only nibbling. There is no breach. A scratch without blood seen there, or a scratch where the swab test is negative, that is spirit swab wipe is negative, is category 2, that requires only a vaccine. But when it comes to deep wound is category 3, we all know. But we need to remember mucosal licks are also category 3, and also tiny scratches where blood is seen, but it is a scratch, is also category 3. So this is something that we miss, because I still remember seeing a child who had a small wound like a scratch on the shin, that is in the leg, and then presenting to it the florid rabies on day 25. So don't remember, always remember, it is not the size of the wound that makes it dangerous. The depth of the wound makes it dangerous. So also again emphasizing, there is no role, in fact, or a very limited role for intramuscular rabies immunoglobulin. Why do I say so? Remember, I had initially told you, rabies virus is not a virus that causes bacteremia or viremia. It remains localized in the site. So we giving an IM rabies immunoglobulin, expecting it to get absorbed into the bloodstream and reach the site of injury in sufficient amount to neutralize the virus is really a far-fetched dream. Because part of it you have already infiltrated locally, and then you are giving a part IM. So don't waste that IM. Try to infiltrate as much as possible in the locally. IM is not really important. Then, can I give extra doses if I have a large and multiple wounds? The answer is no. We cannot give extra doses. Remember the dose, 20 IU per kg for HRIG or 40 IU per kg for ERIG. They are not the minimum dose to be given. They are the maximum dose that can be given. So that is why I emphasize that when you're giving locally, you have a small wound, you need to infiltrate only that small amount of rabies immunoglobulin. You don't have to infiltrate that 40 IU per kg at that particular site, which is a small scratch. It's not needed, because that is not how it is going to work. But you cannot give extra, because immunoglobulin is preformed antibody. If I give extra, then my vaccine may not work properly. So there is no way we can give extra. If you have large wounds, then we have to dilute it and infiltrate each and every wound in the body. Now, again, look at this graph. This will tell you exactly what I'm trying to say. At the site of injury, we already said that virus is there. When you give the immunoglobulin, look at that. It remains at the site. The absorption or the blood level of antibody is so low. Now, what happens when you give the vaccine? The vaccine produces antibodies only after 7 days, but look at the titers. It's so much higher than the immunoglobulin titer that the body produces. So vaccines are extremely important, because washing will remove 70 to 80% of the virus. You giving the immunoglobulin will kill the rest. And 1 or 2 which is left behind will be taken care of by the vaccine. So vaccine also has to be given. If you give only immunoglobulin, you will be able to prevent only 1/3 of rabies cases. So all these 3-prong attack is important. So then many people, when we had vaccine failure, blamed the route of administration, but you need to know, intradermal, if you're giving the vaccine appropriately, it produces a faster rise in antibody and higher rise in antibody, so it is not inferior. But the problem is, it has to be given intradermal itself. if the vaccine becomes subcutaneous, if you're not seeing that wheal at the site of inoculation, it is an invalid dose. Do not hesitate. Just repeat the dose then and there. That wheal has to come. Only if the wheal is coming can you say that the vaccine is in the intradermal plane and your patient is protected. So that is also extremely important. Now, when we had previously analyzed the cases of rabies failure, we had realized that most of the cases, the symptoms had started appearing within 2 weeks of the bite, which basically means that such an early appearance of symptoms basically means that the fault does not lie with the vaccine, because vaccine is expected to produce an antibody rise only after 7 days and peak by 14 days. If symptom itself is appearing by 15 days, that means the virus had entered the nerve long back. So local care is extremely important along with immunoglobulin. Then rarely it can happen that when the bite is happening directly on the top of a nerve, the virus can enter the nerve and post-exposure failure can happen. But remember, that is a phenomenon that is extremely rare, but still it can happen. So what can we do to prevent even that? That is preventing even those post-exposure failure cases, which may be due to direct inoculation. There are only two methods. One is vaccinate the pets and stray dogs. Number two, offer pre-exposure prophylaxis. If someone asks you which is more important, the answer is the first one. If you decrease the reservoir of rabies, naturally the rabies cases will come down. So what about pre-exposure prophylaxis? Pre-exposure prophylaxis is 3 doses, single site, whether it is intradermal or intramuscular. It is 0, 7, and the third dose between 21 to 28 days. This is highly effective. No cases of post-exposure failure has been documented in patients who had previously received pre-exposure prophylaxis. But whenever you're taking a pre-exposure prophylaxis, remember, initially the antibody titers go up and you're protected for the first 3 months. But after that, these antibody titers do come down. But the advantage is that when you give a booster, immediately the antibody titers go up. So here, what do you see here? When you are giving a booster, there is no lag period of 7 and 14 days. The titer jump happens immediately. That is the importance of taking vaccines previously. So what happens when you're taking vaccine previously? Whether it is 3 doses of rabies vaccine or 3 doses of tetanus toxoid vaccine or 3 doses of DPT, these skilled vaccines, when you have taken previously minimum 3 doses, you will have enough memory cells in your body. These memory cells in normal health is doing nothing. They are simply moving around. But the moment a vaccine booster is given, immediately the memory cell will recognize the vaccine antigen and convert itself into plasma cell and start producing antibodies. It does not require the help of dendritic cell. It does not need to go to the regional lymph node and germinal center reaction. All that is not needed. The titer rises immediately. So that is the importance of taking a pre-exposure prophylaxis. So if you take a pre-exposure prophylaxis, for first 3 months, even if you have an exposure, no further vaccine is needed. After 3 months, on exposure, only 2 doses of vaccine are needed. That is 0 and 3. There is no need for rabies immunoglobulin. I had said the same thing for tetanus also. Anyone who has received 3 doses of tetanus does not require tetanus immunoglobulin. Anyone who has received 3 doses of rabies vaccine previously do not require rabies immunoglobulin. And re-exposure 03 is in fact lifelong because the memory cells remain intact unless you are immunosuppressed. Now, another question comes is, many of us like pets and have pets at home. So vaccinating the pet dog at home, is it enough to prevent rabies? The answer is, for your pet to be considered as immunized, there is a set of rules that needs to be fulfilled, and which includes that the current age should be more than 1 year, the first dose of the vaccine should be given after 3 months, 2 doses should have been taken, yearly vaccination should be taken, vaccine should be of good quality. All these criteria are difficult to fulfill, and that is why the Indian guidelines very categorically states that even if your even if your dog is vaccinated, if you have an exposure, you need to take a post-exposure prophylaxis. And the evidence lies in one of the studies done in Trivandrum itself, where they found that among the vaccinated animals, 71.3% only had protective titers. So it is not 100% seroprotection in the dogs who are vaccinated. So never wait for wait for observation, because sometimes remember earlier we used to say observe the pet animal for 10 days, and if the dog is okay, you don't need to vaccinate. No, it is not that, because by that those 10 days the rabies virus would have already entered your nerve, and once it is inside the nerve, we cannot do anything. Now, why did we say 10 days? Because if a rabid dog bites you and the virus is there in the saliva of the dog usually dies within the next 4 days. So if the animal is healthy for the next 10 days, that means at the time when you had a bite, the dog was not infected. It only means that. It does not mean to delay vaccination, because delaying vaccination, you may be missing on important golden period. So irrespective of whether you have an exposure to a stray dog or a pet dog, depending on the category, always get vaccinated, and always consider getting pre-exposure prophylaxis if you are an animal lover or at risk of getting a rabies exposure. As I always say, opportunities to vaccinate are like biscuits dipped in tea, a little delay and it is gone. So don't miss those opportunities. Thank you.
Thank you, Sheeja ma'am, for that lucid and crisp talk as usual. Dr. Nisha, there are a few questions in the chat box.
Ma'am, if the mother is on steroids and immunomodulators, can the newborn be vaccinated with BCG?
Okay, that's a very good question. If the mother is on immunomodulators, especially biologicals, then the baby cannot receive BCG. Especially for biologicals that is there. So definitely the baby cannot receive the chemotherapeutic agents if the mother has received. If the mother is on low dose steroids, that is not going to harm the baby.
And if the child has missed the DPT booster at 18 months and is now coming at 5 years for the second booster, should we give the 2 boosters?
Okay, in this situation, that means this baby is already more than 4 years of age, right? So here you can give the booster on 5 years. You can give the booster at 5 years, but you don't need to repeat the 5-year booster. You have to directly go to the 10-year TD is enough.
Okay, ma'am. The baby presenting with pain and swelling at the DPT injection site and is not bearing weight.
Okay,
So,
this is, I think, this is something very commonly we see. And as I already said, kill vaccine tends to have higher side effects with increasing number of doses. So here we can give paracetamol as well as we can apply local a cloth dipped in lukewarm water or a cold water and can be applied. Not lukewarm exactly, cold water sponges are recommended.
okay, ma'am. So what's the minimum age for influenza vaccine and what's the ideal season to give?
So basically, influenza, in case of Western countries, they have really classical influenza peaks, usually in the winter time. So their vaccination is usually offered the September, October, that time. But as far as India is considered, it is a perennial disease. Always you can have influenza, and influenza peaks usually peak during monsoon. So in Kerala, it is always better that you give the influenza vaccine, which gets released usually in April, March, April release. That vaccine would be better. But in case you have not given that vaccine at that time, anytime the patient comes to you, you can give the vaccine. The vaccines are released at 2 times in India. That is one near the September, October, and one in the April, May. So whenever they come, give the latest vaccine that is available. Minimum age for influenza vaccine is 6 months.
Okay, ma'am. If the child develops adverse events to the petrosis component and if DT vaccine is not available, what is the next option?
A good question, but basically we give DPT, right? So if a patient develops an adverse event, how do we know to which component the patient has developed? It can be DP or T, right? I think the question, what you really meant is if the patient with having a DPT develops a seizure probably or an encephalopathy, what do you do? Probably that's the question you meant. So here, what you need to know that regarding DPT, the only contraindication for DPT is anaphylaxis to previous dose or encephalopathy within 7 days of DPT without a known cause. If the cause is not known and you have an encephalopathy and you blame it on DPT, That is the only contraindication. A progressive neurological disease, a seizure disorder is not a contraindication for DPT. You can. I hope Pratibha, I cleared your doubt.
Madam, what's the diluent for RIG?
Normal saline. Saline itself.
And Dr. Ashwini Agarwal has said that repetitive TT dose may lead to amyloidosis.
But
So,
I really don't have any idea about that, because for me, I only remember that repetitive TT can cause serum sickness. I'll look that up. No idea.
and madam, if a category 3 dog bite wound comes to the casualty, which one is ideally preferred? If we have all the three, ERIG, HRIG, or MAB?
Okay, here I think one is that HRIG availability has become very less. Preferred would always be HRIG, because both ERIG and HRIG are equal efficacy, but HRIG has better safety profile, being a human rabies immunoglobulin. So HRIG will be always preferred. ERIG efficacy, more than the efficacy, the problem is with the side effect. Regarding monoclonal antibodies, since you brought up the question, what we need to know that WHO says that wherever monoclonal antibodies is available, it may be given because of better side effect profile, consistency in the antibody titers, and better efficacy. But there is a small catch there, because the monoclonal antibodies that we have in our market are two types. One is the human monoclonal antibody, which is a single epitope monoclonal antibody. What do you mean? The monoclonal antibody is acting against only single epitope. So in case the rabies virus undergoes a mutation, this monoclonal antibody may not be effective. But the good news is that from India, the resistance have not been reported. So in the Indian population, it is pretty good. But for example, in Africa, the resistance to that particular epitope is more than 60%. So that issue is there. That is the only reason why the national guidelines are currently not recommending monoclonal antibodies till further studies are available. But it is licensed by the Drug Controller General of India. So we can definitely use it. It has a better safety profile. But the limitation also, I told you.
If the person had 2 doses of Covishield, is there any need for booster now?
Okay, basically, I don't think the vaccine is available now. Are we getting the vaccine? No, for me, I think it is not available. So we are not really thinking of booster, even though as far as the CDC guidelines are considered, they are still sticking on to the COVID vaccine and boosters also. But for us, it is not available, and we're really not thinking in that side. It is because it's a milder disease nowadays, so we are really not bothered about the vaccine now.
Okay, ma'am. And regarding the catch-up period for BCG vaccine?
Catch-up period for BCG in the national schedules is only till 1 year, but IAP recommends till 5 years of age. But if it is a patient who has been born and brought up outside India and is now coming to India for residing, can definitely be offered.
And regarding the treatment for BCG adenitis?
No, BCG adenitis, basically no treatment. You just wait and watch. And if it is fluctuant, you can aspirate. If it is too large, you can excise. Otherwise, no treatment. Remember, it may persist for 3 to 6 months. It may appear a little late also. Both are possible.
And if the 11-month-old child presents for post-exposure prophylaxis for hepatitis A with the household contact, can we administer it?
Very good question again. So here the answer to this particular question is, in fact, you can administer. Why because that reference is again CDC. CDC says that anyone more than 6 months of age, if they are going for travel to a hepatitis A endemic area, they can be offered hepatitis A, even though it is not considered as a valid dose and it needs to be repeated after 1 year of age. So in this special scenario, you may offer, but the efficacy is not guaranteed. It has to be repeated after 1 year of age.
And they have asked regarding the ideal site for DPT vaccine.
DPT, commonly, we give the anterolateral part of the mid-thigh till, and after 1.5 years, you can give it in the deltoid. But any age, you can give it anterolateral part of thigh. That is okay. The guideline is after 1.5 years, you can give it in the deltoid. But even that age, it is applicable that you can give in the thigh.
Preferred route for fractional IPV vaccine?
A fractional IPV, fractional, when the name comes fractional, it becomes intradermal. You cannot give it through any other route because fractional IPV is only 0.1, only 1/5 the dose of a normal IPV. So there is no other route you can give except intradermal.
And if there is shortage of DPT vaccine, can we give DPT and HIP combo vaccine at 5 years?
Definitely can be given because HIP, in fact, booster is recommended, not 5 year, at 1.5 year, the booster is recommended. But if you don't have it, you want to give Quadravax at 5 years, absolutely no problem. Extra dose of HIP is not going to harm.
And is it possible to interchange rotavirus vaccines?
Okay, basically, rotavirus, any vaccine, the dictum is do not exchange as far as possible. But if you don't have any other option, you can always give. But as far as rota is considered, imagine the patient is taken from the government sector, then comes to the private, or vice versa. You can continue the schedule with the current vaccine which is available. Because don't deny a vaccine, patient may not go to the other facility for continuing vaccination. So preferable to continue with the same vaccine. If not possible, you can.
And also about PCV10 to PCV13 and other brands.
Yes, PCV can also be interchanged.
And if the child has received 2 doses of MMR, is there any need to give it in adolescence?
So scheduled MMR vaccine in adolescents right now we cannot recommend because the schedule is 9 months, 1.5 years, and 5 years. And when you're giving a 5-year MMR, remember that for the next 20 years of age, you're reasonably protected. But after 20 years, you're definitely vulnerable. So if there is an outbreak in the particular college you're studying, you can always take an extra dose.
If the baby is on post-exposure prophylaxis with IMRV on day 14 and he had a contact with varicella at daycare.
Yes, varicella vaccine may be offered even while the patient is receiving the rotavirus vaccine. Rotavirus, the rabies vaccine, varicella can be offered. Routine vaccines can be given. Often we say that complete the rabies and then we will give, but in such a situation, it can be offered.
Neonatal sepsis on antibiotics. Should we wait to give the vaccines till completion of treatment?
That again a good question because I think the question comes because of the BCG vaccine. Otherwise, other vaccines it doesn't come because they are all viral vaccines. But BCG vaccine also, current antibiotic therapy is not considered as a contraindication, but probably amikacin will have an effect. If on amikacin, I would always say give after the antibiotic is complete.
And for subcutaneous vaccines, we use 1/2-inch needle. Actual standard size is 5/8-inch needle. Is it okay?
Even for subcutaneous, 5/8-inch needle is okay. Only thing is the angulation, right? We'll make it a 45-degree angle so that it remains in the subcu plane. And also remember that a vaccine which is recommended subcutaneously, if it becomes IM, it is still valid. So for example, MMR vaccine, it is supposed to be given subcutaneously, but instead you gave it IM. It is valid. You don't have to repeat it. If the other way around, it becomes invalid. Vaccines which have to be given IM should not be given subcu.
What's the absolute contraindication for vaccination?
Only one contraindication, anaphylaxis to the previous dose. It means for all vaccines when you take, otherwise definitely live vaccines, immunosuppressed, it is contraindicated. Fever is not a contraindication. URI is not a contraindication. Current antibiotic, convalescing from the diseases are not contraindications. A very sick child, you will definitely not want to give. The fever has just started today, then you will say, wait, let me see how it evolves. A URI definitely can be given.
And can the 2 different live vaccines be given in less than 4 weeks period?
No, we cannot give because we said no, when we give a live vaccine, the whole body is involved in an antibody response. So the second live vaccine will not be effective. We cannot give.
Thank you, madam. I think there are no more questions.
Thank you, ma'am, for that exhaustive question answer session. Isha, we'll wind up the session with the vote of thanks.
A wonderful talk anyway. It was very good.
Thank you, sir.
So, good evening to all. I think This will be my last section as the convener for tips. I thank the IAP Kerala office bearers, Shreyas sir, Gobi Mohan sir, President-elect Nandakumar sir, my chairperson, Dr. Jamoni Sebastian sir, and all those who cooperated with me for this wonderful initiative. And as we started the Sheeja Madam's talk on January, and also this time also we had a household attendance right from the beginning till the end, and also many queries. And I thank all those who attended today's section, and big thanks to Madam also for making it too lively. Thank you all. Good night.
Thank you, Nisha.
Thank
Night.
Good